So first, fungal hyphae with Iolscope Recognition Study. No conflicts of interest, no financial interest. My main aim is to compare the efficacy of Iolscope with Zeiss Primos microscope in the identification of fungal hyphae. As we know, fungal keratitis is caused by more than 70 fungus species, which is the leading cause of visual impairment in young and middle-aged patients, which also contributes to visual morbidity and health problems, adversely affecting the resource of the resource and economy of the country. As we can see,
fungal keratitis should be diagnosed early and accurately so that we can give a targeted treatment. This would avoid preventable blindness and vision loss and complications. This can be done using a compound microscope, corneal smear test, fungal culture, tissue biopsy, PCR microscopy, and confocal microscopy. These investigations are very poorly accessible and it costs high. There is shortage of skilled interpreters and there are lack of portability. This all actually delays the diagnosis and further increases the visual morbidity. So we came up with the innovation called the smartphone-based intraocular lens microscope, that is the Iolscope. It has been published in IJO and it requires a chart paper which has punched with a hole and 4 iols attached to it. And then this is attached to a smartphone. The smartphone is then used to take pictures of the fungus on the slide. So in this study, we have included patients with who have come for corneal scraping and got KOH mount and culture done. The exclusion criteria were corneal perforation and contaminated sample and any previous medications. It was a study conducted over a period of 3 months. The sample size was 198. It was done in microbiology department of Aravind Eye Hospital. The patient was priorly taken consent form, and then all medical history was taken. Slit line examination was done, and under topical anesthesia, the slide of KH and for culture was taken. First, we actually took the slide and KOH mount to the microbiologist 1, who was given the Zeiss Primostar to give the gold standard diagnosis. The second microbiologist was given the Iolscope to diagnose the same slide. So results, we gave a total sample of 194, in which fungal keratitis was diagnosed with 83. These are the results of KOH mounted slides, A and B showing rhizopus and C showing aspergillus. These are the other comparative photos. The one in the left is from the microscope, gold standard microscope, and one in the right is from the Iolscope. Here I'm showing alternaria and bipolaris. Next slide, showing curvularia and extrohilum. Another showing aspergillus. So the sensitivity and specificity was almost 100 to detect fungal hyphae. The true positive were 83 and true negative were 111. So keratitis is one of the most causes of blindness. And in our study, we found 42.78 cases of keratitis being mycotic. Males were higher, and the age group of 41 to 60 were higher in numbers. Farmers were the highest who suffered from the disease. And Iolscope has been able to find out the hyphae material of fungus with 100% sensitivity. Species identification is not very accurate. So I would like to conclude that Iolscope is an innovative, cost-effective instrument which can be used for screening device as a screening device for diagnosing fungal keratitis. It can be also a good alternative to conventional microscope at places where conventional microscope cannot be used or setting which doesn't have a conventional microscope. It has wide application in periphery centers, fields, camps, and teleconsultation, especially during the COVID times. These are my references. Thank you.
Thanks, Prithvi. It's a really wonderful tool, especially our colleagues working in remote areas where the microbiologist facility is not available. So definitely it will prove to be a very good tool. Thank you very much.
Thank you.
Our next speaker is?
It's Dr. Bikram.
Okay.
Yes.
I'm sharing my screen.
OSA. Okay. Yes.
Is it visible, sir?
Yes.
Yes. Yes.
A warm good morning to one and all present out here. I am Vikram Dam from Assam Medical College and Hospital, Dibrugarh, and I will be presenting my paper on clinico-pathological effects of smoking on ocular surface and tear film, a novel study in a tertiary eye care center in Northeast India. I am thankful to AIOS for the opportunity and to my respected teachers for their guidance. Tobacco smoking, as we know, is one of the most serious public health problems all around the globe. Cigarette or tobacco smoking is a major risk factor for a wide variety of diverse disorders involving cardiovascular, respiratory, and reproductive system. Our country has been very adversely affected by this tobacco consumption problem. As per WHO, there are more than 120 million smokers, which is around 12% of the entire global smokers. More than 1 million people die every year due to tobacco smoking related illness. The effect of smoking on systemic disease have been very well documented in literature, whereas the effect of smoking on eye is still in very nascent stages. Smoking has been found to be related with the occurrence of graves of ophthalmopathy, glaucoma, ARMD, cataract, hypermetropia in various peer-reviewed literature. The aim of our study was to evaluate the clinical effects of smoking on ocular surface and its pathological correlation with the help of impression cytology. Before progressing on this year-long study, we did an extensive PubMed search to find out similar studies, more so on the pathological aspects of effect of smoking on ocular surface. And as we can see, we did not find much significant literature. Ours was a hospital-based observational study, and all necessary institutional review board and ethical clearance were taken. 80 patients presenting to our outpatient department with refractive error within the age group of 18 to 60 were selected for this study. Patient selection was based on preset inclusion and exclusion criteria. The exclusion criteria was history of contact lens use, age less than 18 years or more than 60 years, history of any ocular surgery for the past 3 months, any ocular systemic disorder which has the potential to affect the secretion or distribution of tears on ocular surface were excluded. Taking 95% confidence interval with 90% power, the sample size was decided to be 40 smokers and 40 non-smokers, and smokers are further subdivided into mild, moderate, and severe smokers. And comprehensive slit lamp examination was done in all patients to assess for signs of blepharitis, meibomian gland dysfunction, conjunctival and corneal disorder. Tear film breakup time was also detected to detect the tear film instability. Schimmer's test with anesthesia was also done to provide a measure of tear production. An ocular surface disease index questionnaire was also given to each participants. Conjunctival impression cytology was done as per mentioned by S.C. Tasang in this landmark paper. Nitrocellulose acetate filter paper from Marek Millipur was taken. Local probe paracaine 0.5% was instilled into the eye. Paper was applied over the temporal interpalpebral bulbar conjunctiva at a distance of 3 mm from the limbus. The paper was kept in contact with the ocular surface for approximately 5 to 10 seconds. It was allowed to get wet completely and then pulled up with blunt forceps and then allowed to air dry. Fast staining technique modified McManus was applied in our study. The completed slides are examined by light microscopy and graded according to Nelson grading system as it is shown here. IBM SPSS software was used for statistical analysis in collaboration with Department of Community Medicine. Now coming to the result, coming to demographic and clinical characteristic, the mean age between the smokers and non-smokers was statistically insignificant. We tried to match the geographical distribution as much as possible. Now coming to clinical parameters, tear film breakup type and basal tear secretion was higher in non-smokers as compared to smokers with significant statistical difference, whereas reverse was the case in case of ocular surface disease index scoring. Now coming to clinical parameters amongst the case population, the mean tear film breakup type and mean basal tear secretion showed a decreasing trend according to the severity of smoking with significant statistical difference, whereas reverse was the case with mean ocular surface disease index scoring. Now coming to the first graphical representation, as we can see here, that smokers have a higher grade of squamous metaplasia than non-smokers with higher numbers in grade 2 and above. And coming to this particular graph, squamous metaplasia grading was found to be related with the severity of smoking. These are some of our impression cytology images. As you can see, in grade 1, we have small and rounded epithelial cells with plump oval goblet cells, and we have intensely past positive cytoplasm. Now coming to grade 1, we had slightly larger and more polygonal epithelial cells, and there was decrease in goblet cell number. Coming to grade 3, we had multinucleated epithelial cells with very few goblet cells here and there. Now coming to grade 3, we had large and polygonal epithelial cells with basophilic staining cytoplasm along with absence of goblet cell. Our study was in coherence with this landmark study conducted by Ahmed Satichi on chronic smokers. The take-home message is that smoking has an adverse effect on clinico-pathological parameters of ocular surface and tear film. More large population-based studies are needed for progress in the field of ocular surface disorder, and impression cytology is a very valuable tool for understanding, diagnosis, and research in the field of ocular surface disorder. This increased use of impression cytology techniques, which requires a multi-departmental effort, can provide us an excellent opportunity for better diagnosis and management of ocular surface disorder in future. Thank you for the opportunity.
Thanks, Dr. Vikram. Your study has further reaffirmed that smoking is not good for health.
Yes, sir.
Thank you.